everyone. We are the Southern Oregon Older Adult Behavioral Health Specialist Group, and we are here to welcome you to our training. We have, let's see, please, let's just do some etiquette. Please mute your mics. We are welcome to questions. Please put them in the chat. Someone will be monitoring the chat during this time. So questions and comments are always welcome. Of course, the slides will be available to you. We will be sending them out. In addition to that, this is recorded and it will be posted on our OABHI YouTube channel, which we will provide you with if you do not have it. Live attendance is required to receive the CEUs today. To receive your certificate of attendance, please complete the PSU survey about today's training. We don't care if you don't like us. We just care that we know you were there. There will be a follow-up email with an evaluation that will be sent out to you within 2 weeks. That evaluation must be completed for you to receive your CEUs. Hey, a little bit about us. We are, again, the Older Adult Behavioral Health Initiative for older adults and people with physical disabilities. It was launched in 2015 to meet the needs of older adults and people with disabilities by improving timely access to care from qualified providers who work together to provide coordinated, quality, and culturally responsive behavioral health and wellness services. Our specialists engage in collaboration and coordination in the systems of care. We help build knowledge, capacity through free workforce development trainings and community education. And lastly, we provide complex case consultations. That link will take you to one of us. There are 24 of us over the entire state of Oregon, and currently there are 5 or 6 of us that are working on this project. Next slide. So what are we learning today and what are our objectives? What advanced care planning is and why it's needy? What are the dementia-specific considerations around personal values and preferences to documentation? What behavioral health and aging services, what behavioral health and aging service professionals can do to assist clients and caregivers with advanced care planning, how to initiate difficult but essential conversations, and where to find reliable resources and support. Next slide. And so let's talk about what's in care planning. First, we're going to explore what matters most to you, informed decisions and preferences. Then we're going to talk about conversations with appointed decision makers, such as families and documents. And last but not least, we will talk about forms and documentation.
And you can go ahead and do the bios. I don't have a slide for that.
No worries. I was like, and we got to tell you about our people.
We're
Okay.
just going to go through the whole slide presentation.
You got it. So today, our presenters, excuse me, will be Angela Franklin, who is a qualified mental health associate and an end-of-life doula. Angela is an older adult behavioral health specialist and suicide prevention coordinator with options for Southern Oregon. She serves Josephine County, and she is her county's Postvention Response Lead and heads the Josephine County Suicide Prevention Coalition. She provides workforce and community trainings on a variety of topics surrounding older adults, behavioral health and wellness, end-of-life support, advanced care planning, and suicide prevention, intervention, and postvention. So that would look like QPR, ASIST, and CONNECT. Angela is a practiced death midwife. She has worked with older adults as a caregiver, hospice volunteer, and end-of-life doula and community educator. She is a founder of Journey Home DeathCare, a community-driven organization based on practical death care, education, outreach, and community grieving support. Thank you so much, Angela, for being here. And next we have Kim. Hold on.
Messiah.
Messiah. Oh, I was like Messiah, but I know that's not it. Okay. Kim Messiah is our certified PAC dementia coach, trainer, and champion teacher. Kim Kasaya has lived in Southern Oregon all of her life. The first person to teach her about dementia was her beloved grandma, and never forgot what it felt like to be an overwhelmed family member while trying to make sense of the changes that dementia can bring. In 2013, she left a 20-year career in the optometry field to pursue working in the senior care industry as a marketing director at an assisted living to follow her passion of helping and working with older adults and their families. The following year, she founded a family member caregiver support group through the Alzheimer's Association in Grants Pass, Oregon, and continues to facilitate it 10 years later, teaching dementia education classes on the behalf of the Alzheimer's Association since 2014. She's found education was the key to understanding and unlocking many of the mysterious of this confusing disease. In 2016, Kim became a certified PAC dementia trainer through Teepa Snow's Positive Approach to Care program, and later a certified dementia coach to help the caregiver apply the training to the individual situations. In 2023, she received her third certification as a PAC champion teacher to offer advanced training and skills to caregivers and families. She has been a trainer for Oregon Care Partners since 2016, in addition to the Alzheimer's Association's long-term care facilities, adult foster care homes, and families. In June 2023, she was honored to teach alongside her long-term mentor, Teepa Snow, the founder of Positive Approaches to Care. We really appreciate you being here, both of you, for this training, and we will turn it over to you now.
Awesome.
Thank you.
Well, thank you. So I wanted to first go over a little bit about what advanced care planning is. A lot of times when we think about this, we think about the forms and documents. And really, the forms and documents are not going to be fully informed or reflect our values and what matters most to us, unless we have that exploration within ourselves and with the people that we care for and our clients. And it really does take the conversations, and we'll talk about different strategies and different ways to kind of engage with people. So why is advanced care planning important? Well, first off, like I said, it provides support and pathways for knowing and honoring one's priorities for future medical care and also end-of-life wishes. It's a way that we can help create person-centered decision-making. We can normalize the concept of planning, and it helps us give a pathway to figure out what someone's goals, preferences to help inform that decision making. When it comes to a person with living with dementia, it is also very important because, as we know, dementia is an umbrella term. And so when we talk about dementia, it is typically a collection of symptoms that are caused by various illnesses and diseases. And so some dementias are reversible, dementias that are caused by drugs, alcohol, hormone or vitamin imbalances, or even depression can sometimes be reversible. But then we have other illnesses such as Alzheimer's and Lewy body dementia, vascular. There's lots of different types of diseases that will lead to dementia. So one of the most common reasons why people lose their ability to guide their own care is dementias. And so we know that capacity is not a static state. So when someone has dementia, oftentimes their capacity is going to fluctuate. So we have good days, we have bad days, depending on the time of day, it can change. And so it's really important to include what we're going to call the decision-making continuum into advanced care planning. And then it's important to get some of the useful information from people as early as possible. That's going to be really important for the decision makers and the care providers. So Kim is going to talk about specifically what information she has seen as being very beneficial when caring for people living with dementia. We also know that people with dementia that's irreversible will gradually lose their ability to speak, eat, and walk. And this process can take anywhere from 5 to 20 years, sometimes even more. Dementia is not something that is just for older adults. There's many illnesses and conditions that will cause dementia that can start at an early age. So as we move through this, I want you to think of this as maybe something to even apply to everyone's advanced care planning. It would be beneficial because no one knows whether or not this is going to be the trajectory of their life and of their health. And so it's really important to utilize the tools and the different considerations that we're going to be going over. Okay, so I'm going to give a really kind of quick intro to advanced care planning documents. And there are other webinars, even on our YouTube channel, that go over this way more specific. So we're going to start with the two main documents when we're thinking about healthcare decisions. And that is an advanced directive and the POST. And so we are in Oregon. Most of the people here joining us today are in Oregon. So almost everything that we're going to talk about is in that Oregon frame of reference. But most of this can be applied to other states. You might have a different name for the documents, but every state has some version of an advanced directive and some version of a POST. So an advanced directive is sometimes referred to as a medical power of attorney or a living will. And so an Oregon advanced directive has a little bit of both of those. So an advanced directive gives a person the ability to authorize a healthcare representative to make healthcare decisions for them when they become incapacitated. So it helps you choose medical treatments, and there are specific scenarios. We actually have 3 scenarios that we decide what life-sustaining treatments we do or do not want in an advanced directive. And also in Oregon, it gives us a section to document our values and preferences. It has a number of specific questions. The advanced directive also, you can say that I've added additional guidance. So addendums, additional directive, you can put that and attach it to your advanced directive. And that's how it will be kept within your medical records. We also have a POST. So POST stands for Portable Orders for Life-Sustaining Treatment. Some states call it the MOST, Medical Orders for Life-Sustaining Treatment, or Physical or Physician Orders for Life-Sustaining Treatment. This form takes our advanced directive and turns it into a medical order. So a POST needs a signature from a physician, a nurse practitioner, a physician's assistant, or a naturopath doctor. So this is not something that you can do outside of those folks. You can definitely have the conversations and do all the preparatory work, but when you have to go get it signed, it has to be with a physician. And in Oregon, we have a POST registry. So they will submit it to the POST registry, and then you will get the original to keep a hold of, and the POST registry will send you some, I actually have it right here. They send you these different things, and we have some pocket cards and even a fridge magnet that you can put on your fridge through the Oregon POST registry. So just to let you know, so this is just to go over the between these two things. So an advanced care directive is a legal document. A POST is a medical order. An advanced directive, anyone 18 years or older can get it, have it filled out. A POST is only for someone who is seriously ill or has advanced frailty. So someone who has a dementia diagnosis and who is younger is not necessarily going to get a POST, but if they have physical symptoms that are attached to their dementia that is posing a possible, I would say they could possibly have a medical event in the next few years, then a doctor would probably agree to doing a POST for that person. An advance directive needs to be witnessed by 2 people or notarized. A POST, like I said before, has to be signed by a medical provider. An advance directive is utilized mostly by hospitals, and a POST is not only used by hospitals, but it is also used by the first responders, paramedics. So an advance directive does not keep a paramedic from doing CPR on someone in your home or out in the community. Only a POST would stop a paramedic from giving you life-sustaining treatments outside of a hospital. So it's something to definitely understand. So both forms are valid only in the state that they originate from. So if you live in 2 different areas, then you need to get the forms filled out in that other state. So, and then also people talk about a DNR. So a DNR is an actual separate document that is facility specific. And so a lot of times people think about the POST as a DNR, a do not resuscitate. And so the POST was created because of the fact that DNRs are facility specific. So that way the POST was able to be utilized all throughout the state of Oregon, and you didn't have to get a separate one for every facility that you're at. Some states actually have a DNR, so it's a little confusing when we talk about advanced care planning. You really have to kind of know what the names are in your state. And if anyone has any questions, you can put them in the chat and we'll answer them at a certain point. So dementia addendums. So we have lots of different examples of dementia directives and dementia addendums. In the state of Oregon, we don't have a separate dementia directive. Even if it says dementia directive, it really is an addendum. So you can add that to your advance directive for it to be followed. And so the addendums, what they do is they provide additional instructions, and a lot of it is based on the stages and the progression of the dementia. And so many of them talk about what would you want if it was mild dementia? And then you step up of what would you want, would that change if it's moderate dementia? And then if it's severe dementia. So to have this understanding that there might be different needs depending on the progression of the advanced directive. And then also I have this link for you at the end of the slideshow and you'll get it. But End of Life Washington is a nonprofit organization who has worked together with some lawyers to actually modify a directive. And they have an Alzheimer's disease, dementia, mental health advanced directive. So this form is a really great form. It talks about a lot of things that I don't hear a lot of other people really talking about when we talk about advanced care planning. They talk about things outside of the end of life, kind of scenarios and options. They talk about not only the preferences in care and treatment, but they also talk about preferences, instructions about dealing with combative, assaultive, or aggressive behaviors. And Kim can kind of talk about that in her section. Preferences regarding the financing of my care, preferences regarding future intimate relationships, and preferences regarding my pets, about consenting to participate in experimental Alzheimer's drug trials, about regarding suspension of my driving privileges, and if a court appoints a guardian, and other documents. So this is like an amazing thing. And I would love to see some of the dementia advocates in Oregon creating something like this. So we don't have it right now. So this would not be a legally binding document outside of Washington, but it's something that you could fill out and attach to your directive as an addendum. And so even though it is not a legally binding document, it does give guidance to your decision makers, which is a really big part of advanced care planning, is having your decision makers understand the things that you do and you do not want. So the power of attorney is a document that is either for finance or healthcare, and that lets you choose a person to help you with your finances or healthcare decisions. Oftentimes it does not go into effect until the person is deemed incapacitated or not having competence. And so power of attorneys can sometimes take a bit of working to actually get them to kick in. So there are in Oregon, there is a power of attorney that will start as soon as the person signs it. And there's also a power of attorney that you have to wait until they have the declaration of incapacity. So you have to decide with the person which one they feel comfortable with. Not a lot of people feel comfortable, just signing that this could take place right now. So, but it's something to have a conversation about when someone does start having the cognition issues, and their decision-making capacity is going to be coming in and out, to talk about that. And we're specific section on talking about autonomy. So advanced directive, like I said, is choosing what kind of medical treatments, and it has the 3 different sections of if you are terminally ill, if you have an advanced progressive illness, such as dementia, or permanently unconscious. So it allows you to express your general values, hopes, and concerns. And then we have the advanced directive or addendums. The thing to know is that if you have a power of attorney for healthcare, if you have an advanced directive filled out in the state of Oregon, that trumps your power of attorney. So if you choose someone as a different person as your healthcare decision maker in your advanced directive, it will override the person who's in your power of attorney. So just to keep that in mind. Okay, so the big part of having successful advanced care planning, and this is when social workers and care providers and people who are maybe outside of the immediate family circle of care, these are the things that you can do to support the person living with dementia, or anyone who is needing to kind of think about what they're going to be doing. So when we do these explorations with them, we want to make sure that we understand their understanding of an advanced directive and a pulse. So we want to make sure that they know what those 2 different documents are. We want to help identify the fears and concerns that they have around making these plans. A lot of people will state that this is a really intense topic and discussion, and they have hesitancy, reluctancy to do it. And so it's good to ask them, what are the fears and concerns around having these conversations, and to kind of address those things. We want to know what conversations have happened. Have they talked to anyone? How are they feeling about talking to people about this? And then we also want to see what their understanding of their medical condition is, and to see what they know of how that might influence their future healthcare decisions. We want to ask, what their hopes are for their medical condition. We also want to ask, if those initial hopes don't happen, then what are your other hopes? So to have that second level of asking about hopes, and about living well. What are the things that they enjoy doing? We want to know about past hospital or serious illness experiences, because a lot of times those are the things that are going to create the stories that will be a part of our fears and concerns. Or they're going to be the stories of why we really want something to happen, because we had a good experience. So it goes both ways, not just the negative experiences, but also what were the positive experiences? What did you learn from those different situations? And not only for themselves of being in the hospital and serious illness, but then also the people around them. Have they had any family or close friends as well? And then lastly, we always want to think about people's cultural and spiritual beliefs, and how those affect our decision making. Some people rely heavily within the family to come together and make decisions together. Other people, have certain spiritual beliefs that are going to inform the way that they are going to have their future health care, and definitely end of life care, if we're looking at that. So once we do this exploratory conversations with them, then the goals of care come in. And for people of all health conditions and all ages, it's really important to understand and have informed decisions around CPR. We want to be able to talk to people about the success rate of CPR, and give it in a way that is not biased. We want it to be neutral. So giving the straight facts on what the success rate is for, people in a healthy condition versus a person who maybe is older and more frail, or even someone who's living in a nursing home versus someone who is out in the community. And so those different success rates, I can give you those in our follow-up email. I can give you a little statistical thing on those. And then we also want folks to know that if you receive CPR outside of a hospital, that it always requires a transfer to a hospital, most likely. And so if you are home and you get CPR, that CPR is not fixing the reason why you stopped breathing or your heart stopped. So you still need to get treatment for those things. And then also we want to ask doctors about the results that they might expect based on your personal condition. And so this is kind of a hard discussion to have with doctors, because we want to give everyone hope that, they're going to be the one that it works out for. But we do want to be giving informed decision making. And so we do want to tell people about the success rate. I often talk about Grey's Anatomy and, the different hospital shows, and how, I think it's like 70% of people who receive CPR, no matter what their condition is, survives and is talking within, a day of getting CPR in these shows. And that is not reflective of the reality of the situation. When we look at healthy individuals who receive CPR, it's about 20% of people that will survive and leave the hospital. When we're looking at older adults in care homes, it's about 2% of people will survive CPR and live over after a year. We also want to talk about severe permanent brain injury. So even if someone has a dementia diagnosis, we don't know if there's going to be a car accident, if there's going to be any sort of thing that could cause permanent brain injury. And so we want to talk about, some of these scenarios. And I have to say, it's very hard to forethink all of these different scenarios. So it's good to keep it simple and, have the conversations of what their thoughts are. So the other thing is when we're looking at serious illness, life-limiting illnesses, we like to find out about what someone's priorities of medical care are. So do you want to live longer? Do you want to maintain your current health, even though it means that you might not be living, as long as you were hoping for? Or do you want comfort care? And we want to make sure that your priorities of care align with the medical interventions that are options. And so these are the ones that are on the post. We have 3 different medical intervention options. We have full treatment that should align with someone that wants to live longer. We have selective treatment that should align with someone who wants to maintain current health, but maybe doesn't want to be on an intubator, or may not want to receive CPR if they have an event, but they do want to receive antibiotics. They do want to, maybe be on a BiPAP machine. And then we also have comfort focus. And so those are people that want to let the natural trajectory of their illness happen and have a natural death. And it's always, always going to be coupled with comfort care, pain management, symptom management, and making sure that they are having the most dignified death that the team can provide for them. So now I'm going to hand it over to Kim, and we're going to talk about what are the dementia-specific considerations, personal values, and preferences to document. I must say that I always go to different dementia advanced care planning trainings, and I felt like there was something missing. There's always something missing. And so after talking to Kim, I was so excited to find out what her experience has been, giving care and supporting people living with dementia and their families. And so what we're going to talk about is an addition that not a lot of people consider as part of advanced care planning. And I would really challenge you all to include this into the conversations that we have with our people. Okay, Kim.
All righty. So, first of all, who are you? Tell me everything. When putting that advanced care planning together, what is your name or your nickname? What do you like to be called? And how would you describe yourself? A lot of times, maybe my first name is Claudia, but maybe my middle name is Gwen. and I prefer to be called Gwen. What do you want to be called? You call me Kimberly, I think I'm in a whole bunch of trouble. Call me Kim. And a lot of times we kind of miss that piece. When COVID hit, I went back deep in the trenches and I worked out of memory care as life enrichment for about 40 plus individuals with mid to late state dementia. I didn't have access to their family or their friends to get a lot of this information. And I had to kind of piece a lot of it together. So this is kind of where some of that experience is coming from. What's your name? And what is important? Who are you? And I'm going to get into that a little bit more. Let's go ahead and go to the next slide. What is your art? What makes you that individual? Do you love animals? Do you like cats over dogs? Do you like helping other people? If you do, how do you help? And do you like a tidy house? Or is your house kind of messy? Do you like it all clean and orderly? Or is that maybe not that important at all? If you like to cook, what do you like to cook? Are you good with numbers? Good with figuring things out? What is your art? What makes you different and unique? Because we're all different and unique. And we all have an art. It doesn't have to be all just about painting or singing. What makes you different? And all of these things, document. We Most of us know at this point we are supposed to document our preferences, but a lot of times we miss that piece of what makes us that individual. Do I like being outdoors? If I like being outdoors, what do I like to do outdoors or indoors? What do I prefer? What are those preferences? All of this information is vital that I'm going to be going over because this is about you and about our person living with dementia. What if you had that opportunity to write down or to document what's important to you before developing dementia? But you do. And put this information together now because all of this information I'm going to go over is vital as to what makes you that individual. We're all precious and unique. And then it can also help our care providers, our family members, in making the best decisions for us if we haven't shared that too. So pay attention. And this is information I found I wish I would have had at the time. I did a lot of research and a lot of digging to figure out some of these things about the folks I worked with. And it would have been so much easier, and I would have been able to provide much better care to them sooner had I had this information. Um, so let's go to the next one. Who are the important people in your life, past and present? What are their names? What are their names? I like to say a lot of us want to go back in time. And sometimes with dementia, that gives us that time machine. Who was important to you? Maybe in your childhood. Who's important to you now? And what are their names? So if I'm your care provider and you call me that person's name, I'm going to have an idea of what role you're thinking I am. Am I your sister? Am I your daughter? Am I your best friend? I want to be able to live in your world. I don't need to live in mine. I want to go to yours. Who's your clergy or minister? Who else has been important to you throughout the years as we go back? And who do you look up to? Who do you listen to for advice? What occupations do you respect? Do you respect, let's say, police, maybe your minister? Who do you listen to? And who are the individuals that are important? Make sure you put those names down because that is vital as well. So let's go to favorites. What is your favorite? What do you love? What's your favorite food? Your favorite ice cream? Your favorite color? What's some of your favorite memories or your songs? Which one was your favorite pet or time of day? Some folks love mornings, others love afternoons, some nighttime. This is all vital information. What's your favorite season? Do you like springtime or fall, summer, wintertime? What's your favorite hobbies? And as you're listing these, if they've changed throughout time, list maybe what was your favorites back then. One of the things with dementia, a lot of times we lose that short-term memory, but we retain the long-term. So include those things from a long time ago. What was your favorite food when you were in your teens or 20s? If it's different from now, write it down, document this, everything. What's my favorite flower? What's one of my favorite smells? Do I like it after it's rained and the smell after it rains? All of this information matters. What was my favorite job and why? And I'm going to get to occupations as well in a little while. What's your favorite shirt or your favorite outfit? What makes you you? You have the opportunity at this point to put it all together and put all these pieces together. What was my favorite car? Maybe if down the road you were to develop dementia and I knew what your favorite car was, I could find somebody with that vehicle and we could take you for a ride. Maybe stoke some of those memories. Vital, all vital. Let's talk about music. Let's go to the next slide. Music is important because it's retained on the right side of our brain. And the right side of our brain is that hardwire. It's one of those things that we don't necessarily lose even as we develop dementia. And you folks have probably have seen maybe somebody they can't really verbalize, they can't really talk, but then you put on some music and all of a sudden they light up, they start singing along or they start mouthing the words. And the reason for that is our language center is on the left side of our brain, which unfortunately the things on the left we don't really retain very much as dementia progresses and advances. But that right side is our hardwiring. And music lives there, that rhythm side. What type of music do you like? Genre. Who is your favorite music artist? What songs do you like? What songs make you happy? What songs make you get moving or get motivated? Get you going? When you're cleaning house, what music do you put on to get you moving? What songs can make you sad? Or what songs do you hear that bring back special times? Maybe it reminds you of your wedding, or who knows, when you were dating and you hear them. And what helps you relax? What helps mellow you out some? And what songs you can't stand and you never ever want to hear them again? When I was working in memory care, some very well-meaning person went through and wrote oldies but goodies. Oldies but goodies. And I had that on over half of my individuals. That's great. Oldies but goodies, but what? Was it old country songs? Old rock and roll? There were no specifics. And I spent a lot of time trying to narrow down that piece. I'd put on different music and I'd watch my folks. If they lit up and they started singing along or if they responded, that's how I put together the playlist. And as I mentioned before, had I had that information prior, I could have provided a lot better quality of care than kind of hit and miss. I found out the hard way, you don't put on Loretta Lynn's song, The Pill. But you figure out, all right, what means something to you? And maybe if I need to help you calm down, I could play this song or I could start singing that. If I need to help you get up and moving and you need some help waking up, what can I play or what can I start singing? Because it's that rhythm side of our brain that we retain. Do you like religious music? What type? Gospel? Nowadays? And the thing is, it's all about you, your music, not mine. When my time comes, everybody knows one of the major things about me, I'm a diehard Pink fan. You put on some Pink music, I'm going to be right there with you. You know you are doing really well when I recite some lyrics back to you. But that's about me. And I want it to be about you and what you can share with me. So, what else? What else is vital information I need to know about you? What are your favorite stories to tell? Who else knows them? Who else was involved? Who knows these stories? Because a lot of times what happens is we still, thank you, we still tell these same stories. And even with dementia, we hear them over and over, and we think we can recite them for verbatim. And as we progress through this journey, a lot of times we still have that tendency to tell these same stories. But maybe we lose that ability to articulate and can't really share them like we used to. So if I know what your favorite stories are, maybe I can help you navigate these stories. One of the lessons I learned, just real quick, I had this daughter come to me and she was getting really frustrated with her mom. Her mom kept asking her, when are you taking me to the fair? When are we going to the fair? And the daughter's like, I can't take her to the fair, Kim. It's February. She keeps saying that. Thought for a moment. It's like, what was significant about the fair in your family? She thought for a moment. She goes, well, mom and dad were really involved in 4-H with us. And it was one of our vacations, so to speak, fair week. And they were there every week or that whole week during the fair. And it was something really special to their family. Mom would talk about Fair Week quite a bit, but instead, in the deep confines of dementia, all she could say was, take me to fair. I want to go to the fair. So what I suggested to the daughter, I said, okay, next time mom mentions the word fair, you take the lead. Go, the fair was such a special time, wasn't it? And talk about the animals that you guys had a part in. We still want to tell these, but sometimes we need somebody else maybe to help us navigate. What are those stories? Your good times, those funny times, how you overcame something or a challenge. What story had really good lessons and why it is that you share it? Or what's just a good story to tell that you like to tell? It's important. And write these down. Write them down. All of this information is important to document, but especially this piece, because maybe you can't always tell them the same way, but maybe there's key or vital words that will help me recognize what you're trying to tell me. And if I know about them, I can help you navigate them. So even though we may have heard the same story over 50 times, and we think we're always going to be able to recite it verbatim, there's a lot of other stuff going on in that memory too. Let's go to the next piece. What is your routine? What is your daily routine? What time do you like to wake up? How do you like to wake up? Do you like to have a cup of coffee? Be by yourself? Do you hop in the shower? What is that routine? Do you on showers or bathing? Do you prefer bathing in a tub versus taking a shower? What time of day do you normally do it? Or is it every day or every other day? And your meals. What time of day do you normally eat meals at? What's your favorite meal of the day? Some folks love breakfast. Others love dinner time or lunch. What is your favorite meal of the day? And also, another thing that would be really important for me to know as a potential care provider, what meal do you have a tendency to eat more at? Because let's say maybe down the road, we're dealing with some weight loss, and I want to make sure, okay, if she eats more at breakfast time, I'm going to make sure that's the time I really want to strongly encourage her or provide those breakfast foods. What one do you eat more at? I know so many of us are so concerned about our weight, but when dealing with weight loss, I want you to be a little bit more plumper. Let's say housekeeping or housework. Is there a certain aspect of it that you enjoy? Do you love doing laundry, but you can't stand vacuuming? What time of day do you normally do that? When you go to work, if you're still working, what time do you go to work? What are my TV shows that I like to watch? When do I watch TV? What are some of the old shows I do watch or I used to enjoy? When do I do my hobbies? When do I relax? How do I relax? Do I like to just sit down, watch some TV, maybe read a newspaper? Do I drink a glass of wine? How do you wind down? And also, what is your bedtime? Thereabout. I know it can change or adjust, but in addition to your daily routine, what's some of the weekly things that you do? When do I take the trash out to the curb. If I go to church, what time of church do I go? Who am I? What is it that I do? Now, what jobs or professions you've worked? And have as many written down as possible. What time of day were these professions or these jobs at? Did I work a night shift for many years? Or was it a day shift? Was it those traditional banker's hours? And what was my favorite job or my favorite profession that I did? And why? Why was it my favorite? What was it that I specifically enjoyed about it? What job did I not enjoy? And why? All about you. Did you manage or supervise others? Maybe, okay, I was a housewife. Who ran the household? Who dealt with the finances? Choosing activities for the family. If I had children, what time of day did I need to get the kids up to get on the bus or to drop them off at school? What about picking up the kids? About what time of day was that? What were some of the things that I did with the kids? Because I've had many individuals tell me, oh, I was just a housewife, I didn't work. Yes, you do work. And include that, have that. Let's go when you get upset. Something makes you really angry, or maybe it makes you really sad. How do you calm yourself down? How do you bring yourself back down? Do you take a walk? Do you breathe? Do you hit something? Do you talk about it? Do you write it out? Do you take it out on housework or your job? Do you hold it all in? Or do you cry? And another piece to that is if someone did need to help you calm down, what would be the best way they could help you? Maybe, can I get you a cup of coffee and we take a walk together? What's the worst way someone could help you? Maybe you just prefer having time by yourself to function. But what is the best way to help you, especially when that amygdala gets fired up a little bit? And the amygdala is kind of that primitive part of our brain that, am I a fighter, flighter, or frighter? And also, when it does get fired up, and let's say you get startled, what is your first reaction? Would you consider yourself that fighter, flighter, or frighter? What would you say you are? So, all this information can help us help you if you were to ever develop dementia. Let's talk about traumas, past traumas. What are they? Who does anybody else know about them? What can trigger them? Is it maybe certain sounds or smells? Is it a time of day? Is it maybe different words or sayings you hear? Could it be the weather? And the thing is, usually all of us have had some form of trauma in the past. And not everybody shares those traumas. But it's vital to also know when your traumas do get triggered, how do you deal with them? Do you hold it all in? And how do you act or how do you respond when they get triggered? And what are some of the best ways to help you when these get triggered. Is maybe a certain sound. I know every summer it seems like we have all the the wildfire smoke that blankets in the community. Some of the folks I've worked with, that smoke blanketing the area, it takes them back to a time when they were in the military. And it can trigger that time. So how can I help you? How can I help you deal with this moment? And who else knows about them? If there's a trauma that nobody else does know, okay. But in this information, this is all about you. And the thing is with dementia, everything always has that tendency to rise to the surface. So have that laid out for me. So let's talk about if you could no longer drive safely. You can't drive anymore, and it's not safe. What is the best way to approach you or to appeal to you that you're not being safe? Is it maybe appealing to, okay, I don't want you to hurt another person with your driving. What will appeal to you? Or what if I can't live at home safely anymore? Maybe I'm leaving the stove on all day long. How would be the best way to approach you and navigate that conversation? Should it be a small group of people, a large group? Should it just be a one-on-one conversation? And the thing is, too, when we're developing dementia, one of the first parts of our brain that's affected is our prefrontal cortex, kind of that filter. But one of the things that's also affected is our empathy, that ability to see things from another person's point of view. I've had many families go, she's just not getting it, Kim. I tell her how worried I am about her, and she's not seeing my point of view. She's not seeing your point of view because that part of her brain has been affected and it's no longer working. That empathy. So, what words can I say to you to help you come around to, okay, you're not safe. We're worried. You should be worried. And maybe they are worried about situations, but they don't want to let on that they are. Having that conversation would maybe my clergy member appeal to me better than my son. Who do I listen to? And again, that's why I want to know who do you listen to, and what professions do you respect? Because maybe those individuals would appeal to you better than me as your family member. So what would work and what would help you? If I needed to move to a community for care, would I prefer maybe a smaller setting with 6 or less people? A medium setting with 15 or less people? Or a large setting with 16 plus? And a lot of times I've found for those community settings, we go back to how we were raised, so to speak. I grew up in a small town. I grew up in Cave Junction. I like small settings. If it's busy and crazy, it's just like when I go down to California and like Los Angeles, I can't wait to get out of there. because it's way too busy. I'm a small town girl. So for myself, being in that smaller setting would probably work better than getting lost in a large setting that reminds me of being in LA. And of course, our preferences can change throughout time. But what's that preference there? What do you think would work out? Now, a lot of times we decide, okay, I'm going to live with family. If I need care, I'm going to move in with my son. But what's that backup plan if maybe it doesn't work out? Or what happens if my care needs become something more than what my family can provide? Or what if it becomes too overwhelming for them to provide those needs? A lot of times, folks like to get that promise from other family members: you'll never send me to a home. And one of the things I ask folks, don't try to exact that promise. I know most people don't want that. But when we exact that promise, most of the people that make that promise to us take it very serious. And I've seen those family members that have made that promise deal with an extra amount of guilt and sadness because maybe it is too much. You are wandering, you're getting up at night and you're wandering around the neighborhood. And I don't have the safety to keep you safe. And your care needs have become larger than what I can do or what I can deal with. And having that, oh, I promised her, try not to ask for that promise if you can. Because most of the time we do want to keep it. We have every intention of keeping it. And if something happens where we can't, it causes so much more guilt and it makes it harder. So just other things to think about. What else? What else? Make that outline of your life story. It doesn't have to be exact, because a lot of times, if you were to ask me right now, yeah, I can put it together, but I can't tell you what year I did this or did that. But write an outline. At the very least, write an outline of this life story of yours. If you can, then write it out. Fill in some of those pieces. What is important or what's useful information to others to know about you? And tell me about you. What's important to you? What matters? Another piece I like to ask folks for is write a letter. Write a letter to yourself. If you were to develop dementia, let's say 20 years down the road from now, what would you want to tell yourself? What would you want to tell your family? What would you want your family to know? And what about writing a letter to your future care providers about who you are and what matters to you? What would you want them to specifically know about you? So many times we folks stay away from this conversation, and it's something that we need to get a lot more comfortable with. Write that letter to your future self. most of the time when folks think, well, if I develop dementia, I'm just going to take myself out in the woods. That's not necessarily a very realistic answer. So, what do you want? And write it out. Write those letters. You can seal them up and keep them if you want, but keep them in a safe spot. Also, share that information, share all of this information with the important people in your life or your decision maker, your power of attorney. Hey, if something happens to me, I'd rather live in an adult foster home versus a large, crazy assisted living. I like to tell my sons, hey, if I ever go to memory care, I'm going to be working on breaking out just to prove that I can break out. So, every time I start watching Shawshank Redemption, something's coming. And pick me up, make me feel successful, drive around the block a couple times, and then bring me back. As I've gone through other folks' journey of dementia, it's taught me a lot about how I would navigate it if it was to happen to me. And maybe sometimes explaining more about what are my intentions? What was I trying to prove? Or what was it that I was actually trying to do? But having all of this info is so incredibly vital. A lot of times we know so much about the different legal pieces, but we don't know about you. And you're at the center of this. This is why person-centered care is so important. And without all of this information, we're piecing it together. So who are you? And real quick, another thing to consider, let's say maybe your children are writing out this information about you. Sometimes they only see you as that point in time as my mom. And they kind of forget you had a whole other life before you were their mom. This gives you that opportunity to put all those pieces together and to share it. So that's my suggestions.
That is amazing. So before we go on to the next section, I just want to say that what Kim is bringing is also a way that we can integrate into how to have the conversations of the harder issues. When we can integrate within these different questions, like some more serious advanced care planning questions, it can kind of cushion. And I think that is, we'll go into that in our strategies for having the conversations, but just to keep that in mind, that that integration of the kind of what some people might think of the more fluffy things to know about someone, what is the art, combined with some of the more possibly more difficult things to talk about. So the thing that I wanted to go next on is it is always important to keep intersectionality in the forefront of our support for people when we're doing advanced care planning. And one of the things that is really important is to understand for different marginalized groups of people and individuals, what are the considerations that we need to be knowledgeable about and be able to speak upon with our clients and people. And so I wanted to go into the different considerations for advanced care planning conversations when it comes to individuals who are trans identifying or gender expansive. And so these are the things that we also want to ask is, what are our values around gender expression? How do you understand your gender identity? Do you understand your gender identity in a more fluid way? Do you want your caregivers to respect your gender fluidity in the event when you are no longer legally capable to advocate for yourself? To understand and know where the affirming healthcare providers are. Does a person want to continue receiving hormone replacement therapy? And who will you designate as your decision maker or your power of attorney? It does not have to be someone of your family of origin. It doesn't have to be someone who is your legal next of kin. It can be someone from your chosen family. And so there is a lot of really great work and research going on around this area. Alexander Barry from the University of Ottawa up in Canada, he is doing a lot of really great work around this. So I have a link to an article on this. The Transgender Law Center has some examples of additions that you can add within your advance directive. So I direct medical staff that they should respect my gender identity as a transgender woman by using only the pronouns she, her, and hers when referring to me, and ensuring that when gendered attire is available, I'm dressed in women's clothing. So when you think of someone who has dementia or someone who can't physically speak, they may not be making a lot of sense to people. And so care providers are just going to go off of what they see. And so if someone is visually, someone assumes that they're either a man or a woman, that might not actually correlate to their gender identity. So if we put this into our directives, we're able to let people know so that we do not become misgendered or do not get that gender affirming care. The next thing, and this is something that when we think about dementia and we think about cognition, and I said before, it's not a static state, you know, so it fluctuates. And people who are trans and gender expansive sometimes also have a fluidity or fluctuation of their gender expression. And so this is a conversation to have with someone, is that there is a lot of fear around becoming vulnerable and being unable to protect against misgendering and other microaggressions. But at the same time, it is possible that someone who before dementia identifies as a trans woman, but then may at times within their dementia identify as a man or a woman. And so really to be able to respect whatever they are conveying at that moment and at that time. And that takes a deeper level of understanding and training within care systems to really be able to see that. So one of the possible things is to add, you know, I direct that care staff should respect my identity as either a trans woman or man or gender fluid. And if my gender expression fluctuates, please use the pronouns I am using when referring to me, and ensuring that when gender attire is available, that I'm dressed in affirming clothing. So it would fluctuate. And this is something that is kind of a new thing that we're discussing and trying to support people who are gender expansive. So I'm going to go into looking at capacity, competency, decision-making, how to support someone, and really looking at the work that we need to do within ourselves to be able to support someone living with dementia and to kind of confront some of our assumptions and our ableist kind of things. And so we want to look at personhood and legal competence pre and post dementia. So capacity, to define that, is determined by a clinician. Competency is determined by a court of law. So oftentimes when we do advanced care planning and someone is deemed incompetent legally, then the plan that we have becomes static because there's this assumption that the person does not have the ability to make decisions for themselves at all times. And we know that with dementia, that is not necessarily true. It will fluctuate. And so even if someone is deemed in not having competency, or if someone is deemed as not having decision-making capacity, we still need to take into account their own autonomy as much as possible. And we'll go into that. So I just want you to think, as a person who's supporting people living with dementia or the caregivers, are we viewing the person with the dementia as an entirely new person with new needs to be respected? Or are we preserving the wishes of a previous self at all costs? And can we have that conversation of possibly, finding the middle ground, that we do want to respect, someone's wishes, but we need to have that conversation with them about how we are ever changing. And so we need to have that taken in consideration. So are we making our decisions based on the assumption that the pre-dementia self is better suited to make decisions than the self experiencing the dementia? And not everyone who has a dementia diagnosis does not have decision-making capacity. We know that it can take a long time or it can take a short time. So we need to have that flexibility when we are supporting people with dementia. So I want to look at the decision-making capacity or the decision-making continuum. And so we need to look at someone's ability to make decisions based on, can the person, one, understand and appreciate the relevant information? Two, can they retain the information long enough to use it in making a choice? Three, are they able to weigh the information in making a choice? And then the last one is communicate their choices in some way. So not all communication is going to be verbal. And so we need to also take in consideration the other ways that people can communicate their different choices. Let me see if there's anything else. The other thing to keep in mind, and I get reminded of this by caseworkers all the time, we cannot keep people from making bad decisions. So because someone makes bad decisions does not mean that they do not have decision-making capacity. So it's just something to always remember. So this continuum, we have three levels in the continuum. We have the independent decision-making. The next is supported decision-making. So someone who maybe needs some assistance in making those decisions. And then we have substitute decision-making. And so that looks like when we have the court deem someone not able, who is not competent. And so what we want to do is make sure that we are living within that supported decision-making as much as possible. Even if the substitute decision-making, if someone is a guardian and needs it, they still need to include the person's values and wishes and their directive instructions within the decision-making process, because we want to maintain autonomy as much as possible. The whole goal of advanced care planning is reducing suffering and elevating autonomy as much as possible. So it's those two things that we're trying to do at all times together. So the ethical tension that happens is, we have that obligation to benefit and avoid harm, but we also need to respect self-determination, autonomy, and choice. So we have to think about this as we are working with people who are having cognition capacity issues. So adjusting to changing abilities, capacity, cognition fluctuates. We need to recognize of the different articulations of wishes expressed through gestures or nonverbal actions or emotions, utilizing, different prompts or different things like cards or pictures or things like that. Oftentimes these things, it takes time. And so when we're in a role that is, kind of held within billable hours and we only have a certain amount of time to do these things, it seems overwhelming to us. So if we're in that role, then we need to research and find the people who can take the time and do these things with people, because it's so vital and important. Like Kim said, what time of day is best? Really understanding with decision making specifically that some people, they're more with it in the mornings. But as they get tired and their body's going through all the stresses of the day, their decision making abilities maybe goes down a bit. So we want to allow for ample time over several meetings, and repeating information if it needs. And then the thing that is good to remember is this notion of biographical continuity. We are not the same person our entire lives. Yet a lot of our advanced care planning documents and conversations are based on this biological continuity. And so it is the conversation to have with the people we're supporting about how we change. And we have a lot of, ageist things that come up where we feel like the older we get, the less useful we are, the more of a burden. And we think of our sense of self and that fear that if we get dementia, that, like Kim said, we'd rather just go out into the woods and just be left to our own. And in reality, a person with dementia is still a person, still can have really great quality of life. And a lot of times it's the family member or the other support people trying to maintain this biographical continuity that is distressing. And so if we can let go of this idea of sameness, of, like trying to maintain who that pre-dementia person was, if we can do that, then we can have people really having a lot better lives than we have fears about, because we are really working with the person in the moment at this time. We talk about mindfulness, and I had a discussion with one of my older adult specialists in another county, and it just came to us of like, we spend all of this money doing meditation, mindfulness, trying to reduce the stress in our lives, clear our minds. And a person with dementia has that ability to just be present in the moment. And that sometimes, is a big gift. It's all how you look at things. And that doesn't take away the fact that things can be really hard. People who have severe dementia, and when their physical ailments start really taking hold, it can be very hard. But we also need to look at what our ageist, ableist kind of notions are as we're working with people. Okay, so choosing a healthcare decision maker, we want to make sure, because not every person wants someone from their family of origin or their next of kin, or someone may not actually have those natural supports. So we need to think about all these different situations. I call it solo agers, people who are pretty much on their own, and we have to look out into the community or even into the support systems to find people who can be our decision makers. So we want to make sure that it's someone who can talk with us about goals, values, and preferences. Someone who can follow the person's lead as capacity fluctuates. Talked about the trans person with dementia. So someone who can take the lead and kind of see what they are doing. I think someone is unmuted, possibly. The next thing that we want to do is we want to make sure they follow your medical intervention decisions. So within the advance directive and the POLST, to make sure, even if they disagree with them, that they will follow them, and to have those conversations about why you're choosing those different options. And we want someone who can advocate on our behalf. We know that there's a lot of turnover. We know that there's a lot of different opinions about things when it comes to health decisions and end-of-life care. So we want to make sure the person can advocate and that they can make decisions in difficult moments. The other thing to consider is, as far as an advance directive goes, even if you do not have a decision maker, you can still put all of these things down in your advance directive, and it should be followed. It doesn't mean that it absolutely is going to, but it does give guidelines and preferences that the healthcare staff can take into consideration. Okay, so next of kin, just to give you, so this is the line of next of kin: spouse or domestic partner, adult children, parents, siblings, grandparents, and it goes down. Domestic partner, not every state has legally recognized domestic partners. So you need to make sure that there's not an assumption that they are going to be able to legally be your decision maker, because next of kin, without an advance directive, those are the people that are going to be making decisions for you. With or without without an advance directive, it defaults to your legal next of kin. So if you're estranged from your family, you need to make sure that you appoint your chosen people and not necessarily your legal next of kin. So if your decision maker is not your legal next of kin, then it's really good to share it with them, just to make sure there isn't any contention more than necessary between your designated decision maker and your family or your next of kin. So we want to make sure that we share, our documents and maybe conversations if it's possible. The one thing that I wanted to add, I like adding this in all of my advanced care planning, is after death care. In Oregon and most states, there is a document that you can appoint someone to make your after death care decisions. And so this is Oregon's. It's called the Appointment of Person to Make Decisions Concerning Disposition of My Remains. Disposition means what's going to happen with your body. And so this is a really good thing to have in place if you do not have a pre-need agreement already set up with a funeral home. You can sign this, and then someone who is not your legal next of kin can make those decisions with a funeral home after you die. So this does not go into effect before you die, but after you die. Okay. So how we start the conversation. So I want to talk about advanced care planning is not best done in one giant conversation. It can be very overwhelming for people. And so it is best to think about this as an ongoing process. If you're working with a client, to kind of break this up over an amount of time and to include these questions in informal conversations. And so the other thing, and this is also things to maybe suggest to caregivers of people that you're supporting, is to say, the conversation sometimes is best received if it's given both ways. So to start off by saying, this is, I've been thinking about what I would want when I am at end of life, or if I started, having memory issues. I think that this is what I would want. What would you want? So you make it both ways and it becomes less of an issue sometimes. We also want to be able to be flexible and change our approach. If the person seems to be having an issue or getting a little bit freaked out, maybe change your approach. And we'll talk about some of those approaches. We want to ask, what are their concerns? If they are seeming to having a difficulty in having these conversations, what are the concerns? And the magic words that I tell people in trainings across all of the different things that I train on is the magic phrase, tell me more. If you get stuck and you don't know where to go, you can just ask them to tell you more about whatever. And it really does work. And we want to remember that we want to keep it simple. If someone, the capacity fluctuates and people get overwhelmed, we want to try to keep it as simple as much as possible. Some of the things, conversation starters for advanced care planning, these are typical ones that I do for my just general advanced care planning. Have you thought about the options for your last stage of life? Whom do you want to make decisions when you can't? I was thinking about what happened to Uncle so-and-so, and it made me realize, pulling from your observations of other people's experiences could be a good entryway into having conversations. And then, even though you're okay right now, I'm worried that, if you do start progressing more with your dementia, I want to be prepared. So can we talk about some things that matter to you? And then, when your sister died or when so-and-so died, do you think their wishes and priorities were respected towards the end of life? And it's that exploratory conversations that we were talking about to find out what their experiences have been. And so some of the other approaches that can be somewhat fun. I enjoy these things. We have different games and events. So we have different card decks. We have the Death deck. We have the Go Wish deck, which you can purchase, or there's an online free one that I have a link to. So you can do it online digitally. And they're questions that are kind of sometimes fun, sometimes serious. But it's something that you can do with a group of people to do that both ways type of thing. We have events like Death Over Dinner or Death Cafes. And these are, the Death Over Dinner has a set of questions, and you have a dinner party and you invite all of the people or families. I've kind of instigated families to do this, and I've gotten really good responses back. And then Death Cafes is something that is just a group-led discussion about death and dying. So it can kind of warm people up to the idea of thinking about things more. We have the Conversation Project, which is a national nonprofit, and I have the website linked. They have starter kits for having conversations, and they have one specifically for people with dementia. And so there's workbooks, there's lots of different things. So there are ways to have the set of questions. But like I said, none of these actually have the specific questions that Kim has put forward. So I would love to, to create, a more expansive, thing for people living with dementia. We also have the opportunity to watch movies. And we know that there's a lot of movies that touch on this topic. And then after we watch that movie with them, then maybe we can have a conversation and talk about what they thought about the movie and then move it into their own personal experience. Music, there's a lot of music that can elicit, feelings about different things. There's also that, like, what song would you want played at your funeral? If you could have one person in your life sing a song, what would it be? Or saying like, you know what, you've listened to you're driving in a car with your person, or and a song comes on the radio, just like out of nowhere, it's not planned at all, and you're like, oh, I think I would want this song to be played, either at end of life or whatever. And then the last thing is there are trained people who are trained to facilitate these conversations around advanced care planning. And so not every area has those people, but they are there. And so I train people to give facilitated conversations. So if you're in Oregon, reach out to me. And there are other folks that provide these trainings, and they're all throughout the healthcare system. We know that our doctors have like 15 minutes for everything. And so even though doctors can bill once or twice a year for advanced care planning conversations, it doesn't happen often. And 15 minutes is not enough time to do any sort of exploration really around what's important of why we're doing these things. So we need to bring it outside of just our doctor conversations and include and build the capacity of us as people within aging services and behavioral health supports to be able to normalize these conversations and planning as much as possible, because we're really the ones that are seen as trusted individuals to a lot of people. Okay. Kim, is there anything that you would want to add to conversations with family members?
I think you covered it pretty well.
Sweet. So we're almost finished. And so I just want to go through when to revisit our advanced care planning documents, definitely, but then also to have more conversations. And we call the 6 Ds. So every 10 years, so every decade, when there's a divorce, when there's a diagnosis, a new diagnosis, when there's a decline, when there's a death, and distance. And these really think about like for the person doing the advanced care planning, and then also their decision makers. So if someone appoints someone and that person dies, or if that person themselves starts having cognitive issues, then we need to assign someone else and do that. When we're talking about someone who has been diagnosed with a dementia, and I'm going to keep saying this, capacity fluctuates. So we need to use supportive decision-making and revisit our plans as much as possible. And so it is really important to utilize that supportive decision-making when we can. The last thing is creating a death file. So this is a list of all the different things that's great to have in order before someone lose the ability to get them themselves. And you will have this in the slides. So we'll do that. And then resources. There are more resources than I could put down on here. So I put some general resources about dementia, the Conversation Project, End of Life Choices Washington. We have a great website called Oregon Funeral that is outside of the funeral industry, people talking about how to do funeral planning. So it takes away the capitalistic view and really presents unbiased information. We also have lots of advanced care planning for people with living with dementia. And this guide on advanced care planning resources, it has live links to so many resources. So I'm not going to double down on, those things. We have the Dementia Directive, which is an example that can be utilized. We have the Conversation Project Starter Kit. And then we also, this is a really great eye-opening article that was written by Andre Barry about end-of-life documents for trans people with dementia. And so it is just a really great read to make you think about some of the more ableist type things that we normally don't think about. Okay, so I wanted to end before we have just a few minutes for any questions, just to empower yourself and others to support people and sustain agency and autonomy for people living with dementia, and really to do as much as we can to reduce the suffering. So I want to open it up. If there are any questions, I'm going to stop share so we can see faces if need be. Are there any questions of folks or any comments? I'm going to take this as we did a really good job, Kim. Otherwise, yeah. So I am going to give it to Angela Jensen. Are you closing us out, or Janine? You are muted, Janine.
Janine, you're muted. One question in the chat. Yeah. When someone is traveling across multiple states, is the POLST recognized?
It is not. So it is under the discretion of that specific facility whether or not they're going to uphold it. And so it's always good to travel with your documents, especially if you have a condition that you know is possible that you will need to enact it. Travel with it and hoping that you can advocate for them to uphold it. Otherwise, if you're in a situation where you know that it is definitely possible that you could stop breathing or your heart could stop, go ahead and make concerted effort to try to get someone in that other state to sign off on a POLST, which is difficult because we know it's difficult to even get doctor's appointments in our own home states. So yeah. But if you live if you're a snowbird and you live in Arizona, just make sure that both of your carers are giving you the POLST.
Great question. And great presentation. All good info and very timely. So thank you, everybody, for giving us the gift of time. We would like to give you 2 CEUs, NASW board-approved CEUs. You will be receiving the slides and any other pertinent information that the speakers would like you to have. We always send that out. And you will also be receiving 2 invitations to participate in surveys. One will be from Portland State University. We ask that you give your feedback. Portland State provides the data analytics for the OABHI statewide, and every bit of feedback we can give them is helpful for justifying the continuation of the Older Adult Behavioral Health Initiative. So we would appreciate your help there. Your NASW survey should be coming in a couple of weeks at the latest. You will have to return the survey in order to get your certificate. So May, or I should start with April, we're taking a break. We're taking a break in April. So no programming for April. We hope to pick back up in May with some information, oh, sorry. Had a little spaz there. Information on chronic pain management in the older adults. And so we are working on getting you a speaker through OHSU. We hope to have that nailed down soon, and we will give you the specifics ASAP. So until then, everybody, take care of yourselves, take care of each other, be kind, reach out to us if you have questions about this presentation or any of the others we've given in the past. You can reach us at oabhi@optionsonline.org. And if you found your way here just by accident, let us know if you want to be put on one of our distribution lists to receive regular invites to further trainings. All right, that wraps it up. Bye-bye.
Thank you.